It's a real pleasure for me to be here giving the introductory speech for the PSBE Symposium, because to join PSBE for me was really a pivotal moment. I joined the organization in 2021, and I had been interested in psychedelics for a long time already, but I felt like maybe there wasn't the right momentum in Belgium to conduct research on the topic. And when I joined the PSBE and realized that there was a community of passionate, competent people, it really gave me the motivation and the inspiration to go down that career path. So yeah, it's quite symbolic for me to be here. Here, this is my presentation. I just want to quickly poll as well, who knows very little about psychedelics? Okay, because my presentation is quite dense and I want to know what to focus on. So I'll go briefly through the historical roots and introducing psychedelics and dive a bit deeper on the second part of the presentation. I have no financial conflict of interest. I'm a member of the PSBE and the Mind Foundation in Germany, and I co-founded the Isala Fund, with which we try to support academic psychedelic research in Belgium. So when we talk about psychedelics, what are we talking about? And here I'm taking a broad definition of psychedelics to include also other compounds that have a more, slightly different yet resembling effects and a different pharmacological mechanism, to include MDMA, which is also called an empathogen or entactogen, to touch within. Ketamine, which is also called a dissociative, as in dissociating from one's body's perception and senses, and ibogaine, which is also called an onirogen, to induce dreamlike visions. And then we have the so-called classic psychedelics or serotonergic psychedelics. I'm sure Dimitri will dive on the psychopharmacology of those later, to include psilocybin, which we find in magic mushrooms, mescaline, which we find in cacti, the most famous one being San Pedro and peyote, DMT, which we find in a variety of plants, but it's also produced by the human body, ayahuasca, which is a DMT-containing brew, but it's mixed with a MAO inhibitor so that it can have psychoactive effects when ingested orally, and LSD, which doesn't need an introduction. And so the serotonergic psychedelics are called so because one of their primary mechanisms of action is partial agonism of the 5-HT2A serotonin receptors in the brain, which we find in the cortex, among others, and you can see that they resemble the molecular structure of serotonin, which we produce. It's a neurotransmitter and neuromodulator in the brain. So what are psychedelics? Psychedelics come from the Greek, and it means mind manifesting. And for the little story, it was coined by Humphrey Osmond, who was exchanging letters with the writer Aldous Huxley around 1956. And Huxley had some experiences with mescaline, wanted to find a name for these substances that induce such different effects. Actually came up with something that I realized this morning but forgot. That was not psychedelics. And then Osmond suggested to Phantom Hell or Soar Angelic, just take a pinch of psychedelic. And so the name was coined. We say that psychedelics induce a non-ordinary state of consciousness, but one of the primary aspects of the experience is that it's ineffable, so impossible to put into words. However, scientists will like to describe things, and it makes sense that it's ineffable because it's just such a different experience. It would be like trying to explain colors to someone who is blind, or try to explain dreaming with someone who doesn't sleep. So I'm still going to try. We use a scale in research which is called the 5-dimension altered state of consciousness scale to assess the subjective phenomenological effects of the experience. And here you can see in dark blue the scores of MDMA, in light blue the scores of ketamine, and then in yellow and red psilocybin and LSD respectively. What we see is characteristic is a blissful state, a state of joy, euphoria, inner peace. Spiritual experience, we hear a lot of mystical experiences. Experience of unity, which is somewhat related to the concept, feeling at one with the universe or at one with the space. Synesthesia, that's a mix in senses modality. So the most popular or the most common with psychedelics is audiovisual synesthesia, where you will basically see the music. So the music is going to produce sort of dancing, dynamic shapes in front of your eyes. And this is connected to elementary imagery. So under psychedelics, with closed eyes, you might see all sorts of shapes, fractals, kaleidoscopic patterns. And with open eyes, you might see tracers, also kaleidoscopic or holotropic-like patterns. And then also complex imagery. So with eye closed, you might see scenes, people, animals, like a dream, kind of, or it can be very different. With eyes open, you will mostly have illusions and little hallucinations, so things will look slightly different, but it's quite rare to see completely new things, although possible. Rational, logical thinking is slightly impaired on psychedelics, and also it's hard to be very goal-directed, so we talk about impaired control and cognition. Then we have disembodiment, which is, you see, scores higher with ketamine, which is a dissociative. So disembodiment is to be disconnected from one body's sensations. And anxiety, which scores quite low, but is characteristic of the psychedelic experience and can be present. And I will get back to that later. So a little bit of history. As Natalia said, psychedelics have been used all over the world by humans since ancient times. We actually have sources in 4000 BC of psilocybin paintings in caves in Europe and North Africa. Sorry, I shouldn't look at the slide. And North Africa. We also have around the same time periods traces of peyote use in the Americas. Fast forward to the Common Era, and around 1500 in the Common Era, we have sources of Aztecs consuming what they call the flesh of the gods, which seems to have been hallucinogenic mushrooms. And then in Europe, actually, so-called witches, where it seems using, psychedelics in their potion, in their magic brew. And so back then, psychedelics were used for ritualistic purposes, for healing, and for enjoyment. And they have been rediscovered in the lab. Actually, we often forget, but already at the end of the 19th century, mescaline was isolated, followed by ibogaine and MDMA. But I'm going to zoom in on a very particular moment for psychiatry, and that's in 1938, when LSD was synthesized by Albert Hofmann. So Albert Hofmann was a Swiss chemist working for Sandoz at the time, and he was looking for an analeptic. An analeptic is a circulatory and respiratory stimulant, so very different to the altered state of consciousness of psychedelics. And he was deriving compounds from ergot, which is a fungus. So he synthesized LSD-25, and on rats it seemed not to do the trick, so he kind of forgot about it. Until 5 years later, he had the intuition that he should maybe get back to it. So he resynthesized the LSD-25, being very careful not to contaminate himself. However, he was cautious, but not cautious enough, because the next thing we know was the first LSD trip of history, which was not intended, on the 16th of April, 1943. I'm just going to read an extract from his book, LSD, My Problem Child. Last Friday, April 16, 1943, I was forced to interrupt my work in the laboratory in the middle of the afternoon and proceed home, being affected by a remarkable restlessness, combined with a slight dizziness. At home, I lay down and sank into a not unpleasant, intoxicated-like condition, characterized by an extremely stimulated imagination. In a dreamlike state, with eyes closed, I perceived an uninterrupted stream of fantastic pictures, extraordinary shapes with intense kaleidoscopic play of colors. After some 2 hours, this condition faded away. So we might have thought the same. Hofmann thought, let me try again. He was cautious. Again, he only used 250 micrograms of LSD for his test. And again, cautious, but not cautious enough, because 250 micrograms of LSD is quite a high dose. And this is still commemorated today on the 19th of April as Bicycle Day, because he started feeling the effects. Because of wartime restriction, he could not take the car, probably luckily. And so he asked his lab assistant to escort him back home with the bike. And he was in quite some distress because he started, having a very distorted vision, hearing sounds differently, a lot of anxiety, paranoia. He would later describe this as being in a fun house, where like everything gets distorted with the mirrors and stuff. And he thought he was dying and felt actually grief for his poor children that would grow up without a father. So he asked for his doctor to come. His doctor took his vitals, everything seemed fine, and gradually Hoffman could relax and start enjoying the effects. The next day, as he wakes up, he feels clear-headed, refreshed, a sense of well-being, and thinks, okay, let's find a use case for this. That was also what Sanders thought. And that's basically what we call the first or the second wave, depending on how you place it, of psychedelic research in psychiatry. What we often forget is in the 50s and 60s, over 40,000 people were treated with LSD under the name of Delicid in psychiatry. But Delicid didn't stay within psychiatry. Oh, wait, no. First, so these are reports from a researcher, Schwellers, and his team who conducted research at the time, and you can see some interesting things, some quotes. The reports from patients and volunteers suggested the occurrence of marked loosening of repression and greater facility in recognizing conflicts. So here we are, of course, talking about, psychological repressions and inner conflicts. These are the conclusions from some research he conducted with people with alcohol use disorder. The conclusion is reached that self-surrender and self-acceptance are more easily achieved in the LSD experience, and the thesis is developed that the resolution of the problem of the person with alcohol use disorder lies in this surrender. There were also less lucky uses of psychedelics, for instance, studies with LSD in nonverbal children with autism without really informed consent and this type of thing. So the ethics wasn't always there as we hope it is today. So psychedelics escaped the labs or just got out of the labs and quickly became associated with the countercultures and the hippie movement, and following a sense of moral panic and some specific political incentives for the Nixon administration. The Nixon administration declared a war on drugs, which we know today hasn't been very effective, and psychedelics were basically forbidden. Also by the United Nations, they were rescheduled as Schedule I controlled substance. That means they are illegal to use, but also shouldn't be used in a medical context. And so what we can see is after a wave of interest in psychedelics, which is reflected here in an increase in scientific publications on the topic, we see a drop with the substances being banned because it became not forbidden, but much more complicated and stigmatized to conduct research on psychedelics. However, since the end of the 90s, we have been witnessing an exponential, a quasi-exponential interest, resurgence in interest in psychedelics and psychedelic research, which has been called the psychedelic renaissance. And here I'm going to, take you a little bit through the psychedelic renaissance, but I'm going to try and take a more sober position because we have been exposed to quite a lot of polarities regarding psychedelics, going from, very big fears of LSD having considerable damage, on someone's psyche, but also on babies and things like that, to somewhat sensational depiction of psychedelics in the media. Here, the Netflix series How to Change Your Mind, which was inspired by the Poland book How to Change Your Mind. And there has been a general call in the scientific literature to try and take a more, sober look at this substance, to mind the psychedelic hype, and to try and characterize the risk and the benefits more, objectively. Also, we always try to be, not just for depression, but in general. And for that, I'm going to zoom in on the risks, and then on the benefits. It's going to be quite, superficial for the sake of time. And so, look at safety first. What does it mean, a Schedule 1 substance? It means that it's a substance that has a high potential for abuse and no accepted medical use. It's interesting to think about no accepted medical use since, as I said, 14,000 people have been treated in psychiatry in the 50s, 60s with good results for some conditions. What about high potential for abuse? So this is a seminal study that was published in 2010 in The Lancet by Nutt and colleagues. And it's a Delphi consensus study. So what they do is they gather experts on a topic, here on the topic of drug, and they ask them to give their opinion. Here, the exercise was to score 20 different drugs on 16 different categories that are broadly about harm done to self with consuming these drugs and harm to others. So to self will include mortality, injury, dependence, psychological harm, and to others will include, criminality, theft, family problems, damage to the environment as well. So first we find the highest score is for alcohol, which is, as you know, broadly socially accepted substance. And very much down the scoring, we find ecstasy or MDMA, LSD, and magic mushrooms. And this just goes to show that, the law isn't always aligned with the empirical data. More recently, in 2022, Nutt and colleagues, the first author is Schlag, published a review where they look systematically at the adverse effects of psychedelics. And they look at, the risks that everyone kind of thinks about, such as dependence, abuse liability, harm to self and others, challenging experiences, mania and psychosis, suicide, and hallucinogen persisting perception disorder. That's a disorder when you basically keep having visual effects of the psychedelic experience much later on, and it causes distress. Then they also look at the physiological risks, such as neurotoxicity, overdose, and the cardiovascular risk. I don't have time to go in depth, but I will read you their conclusion. Our review shows that medical risks are often minimal and that many, albeit not all, of the persistent negative perceptions of psychological risks are unsupported by the currently available scientific evidence, with the majority of reported adverse effects not being observed in a regulated and/or medical context. And I would like to specify this, regulated or medical context to therapeutic and supportive context. And I'm sure that Mark will dive into that later, but for the sake of being able to follow along, I'm just going to quickly introduce the therapeutic framework, which we use today in clinical studies looking into psychedelics. And to understand that framework, I'm going to take you back to another big, author, psychiatrist, and researchers that did a lot of research with psychedelics in the 50s, 60s, in the Czech Republic and in the US, and that's Stanislav Grof, who said that LSD and other psychedelics function more or less as non-specific catalysts and amplifiers of the psyche. And so what this means is that basically whatever is there will be amplified. And that goes for external stimuli, such as, is there something happening with the light? I don't know. Okay. These kind of external stimuli, such as, sounds and visuals, the people you are with, the social context you are with in a festival, in a room, in nature, but also for internal stimuli. That's going to be your cognitions, your thoughts, memories, also potentially traumatic memories, your emotions, and your physical sensations, including interoception, how you feel your body. And basically, this, this observation of enhanced sensitivity under psychedelic gave rise already back then to the concept of set and setting, which I guess most of you know, which refers to the mindset of the person and the context in which the person takes a psychedelic. And it's with this in mind that we design basically that we use a specific three-phase process in psychedelic therapy, which starts with preparation, because what we know is that basically the person has to feel safe. And so the goal of preparation is for the participants, when it's a study, to meet with the therapist. It's often a dyad, a man and a woman, and to start building trust, therapeutic alliance, also to help, prepare for the effect of the psychedelic experience and set an intention. What does the person wish to get out of it? There we also train the general attitude that we encourage towards the psychedelic experience, which is going to be one of curiosity, openness, and trust. Then comes the dosing session. In studies, it's mostly 1 to 3 dosing sessions, although I want to point out that, it's probably not enough. If this is going to be, rolled out at a larger scale and we really want to help people get better on the very long term, it's probably not going to be enough to have just 1 dosing session. But so the dosing session, basically the person is lying down, can wear eye shades and a mask through which they listen to music. It's going to be a curated playlist, mostly instrumental because, lyrics may induce a more analytical process, which is not what we want. And the person is encouraged to really go inwards. The therapists are just sitters, so they sit there and they are there to, make sure the person is safe if they need to go to the toilet and are a bit disoriented and stuff, and to provide support if that's needed. But they are not going to really interact with the person unless it's needed. There is a lot of anxiety, the person wants to share something, and so on. They might check in from time to time. And this is, it depends on the compounds. But so for psilocybin, it's going to be 4 to 6 hours. For LSD, that's much longer. It's going to be up to 12 hours, which makes it also more challenging to use in the clinic. And then we go to the integration. And that's a topic, actually, that's discussed a lot at the moment. The truth is we don't really know yet how to optimize integration, but the goal of integration is to support the person in their process of making sense of their experience and also try and see what concrete changes could be implemented based on the experience in the person's life. Because sometimes compartmentalization might happen. You can live a very, very intense experience, but it's not simple to then go back to the environment that's the same and change habits, attitudes towards life, and so on. Here you can see the psychedelic room we use at the Brugman Hospital. And I just want to quickly dive in on a topic related to the therapeutic framework. We have all heard of bad trips, and it is true that during the psychedelic experience, there can be a lot of intensified emotions, including less pleasant emotions, and that can induce more challenging experience with anxiety, panic, and paranoia. Now, it questions our framework in psychiatry, where you would want to avoid these unpleasant emotions. So are these adverse effects? And the truth is, in studies, they are not per se considered adverse effects. They are seen as, psychological and emotional content that can be explored with therapeutic support, and that's very important. And also, it's important to understand that that does not go to say that psychedelic experiences cannot be traumatizing, because they can. And it's really important and hard, also at the clinical level, to be there, support the person, and be able to assess, when it's too much. In studies, we always have rescue drugs available as a last resort. That's going to be, benzodiazepine or antipsychotics. If there is too much anxiety, or olanzapine, antipsychotics, if there is a loss of contact with reality. The truth is these are almost never used, But I think it's important to state that there is really a fine balance, and there is data suggesting that when the challenging experience is too long, 10 hours with LSD, it can have quite traumatizing effects for people. So here is a quote from a study on alcohol use disorder to illustrate the concept of challenging experience and how they can be seen as psychological material. In the second session, she received a higher dose of medication and experienced an amplification of thought, moving her into a confused and chaotic state. Underneath the chaotic thinking, she identified a deep well of overwhelming sadness. She was able to eventually surrender control over her thoughts and entered into a state of peacefulness until her thoughts quieted completely. And so this illustrates the dynamic nature of the psychedelic experience, and also that when you feel like you can go deeper, you might find under the chaos sadness, under the sadness a peaceful feeling, and so on. When we talk about safety, it's important to state that there is a fourth part that's very important in psychedelic research, and that's the screening. Indeed, we don't include, everyone. We have actually quite strict eligibility criteria, Here you have an extract. This is by far not all the criteria, but so they go from physiological considerations. People with uncorrected hypertension we exclude. You know, it needs to be treated because we just know that psychedelics can slightly increase blood pressure. But then more on the psychological or psychiatric level, we do not include people with a history of psychotic disorders or bipolar disorders type 1 and 2. That second one might change with upcoming safety data, but because the fear is to induce a psychotic episode or a manic episode. And this also extends to people who have relatives with these disorders, because we know that there is a genetic component. So if it's in your family, you might be at higher risk. So we are being very cautious with that. Significant risk of suicide. It seems that psychedelics actually reduce suicidality. That's been shown in reviews and meta-analysis. However, the psychedelic experience can be very destabilizing. So someone who is in this moment really in a phase of high suicidality, it might not be the best idea to go and really destabilizing them further. This is a real problem for, inclusivity. People who have had a long history of, psychiatric care often are under a lot of medications, maybe antipsychotics, and it might not necessarily be to treat psychosis, antidepressants, things for sleeping, things for aggressivity, a lot of medication that can have an interaction with psilocybin or other serotonergic psychedelics, and therefore we cannot include them in our study, or they would have to taper off the drug under medical supervision. And then here, high risk of adverse emotional or behavioral reaction. So that's to talk about all kinds of things, but it could be also people with so-called severe personality disorders. And what I think is important to state here is that we don't have any data to know from contemporary study whether people with severe personality disorder might benefit from psychedelic therapies or not. But what we do know is that these experiences are very intense. Participating in a clinical trial is also very intense because you have a lot of care, you have follow-up, and then it's over, and that can really feel as abandonment for someone who has a high sensitivity to it. And if we want to test or explore whether that could be helpful for people who have a really strong emotional sensitivity and a strong, sensitivity to abandonment, we will really need to be able to develop the right framework of care. So we don't include people with those traits or difficulties at the moment, but it doesn't mean that they will never benefit from these. Okay, this slide I wanted to hide, but I couldn't, so I'm just going to pass it for the sake of time. And if there is one thing I hope you will remember from my presentation is to go and watch this video. Mariam Jabir talked actually in an event that was organized by Tadeusz, who will be talking later. And it's just, I cannot do justice to her testimonial, which is incredible. She just has a way with words. She was a participant in a COMPASS trial for treatment-resistant depression, where she received 25 milligrams of psilocybin. And why I'm talking about her is because her case or her experience really illustrates the complexity of treating people with psychedelics. So she had a very challenging experience, an increase in suicidal ideation in the week following, and was classified as a non-responder, as in, her depression didn't improve with the treatment, at least not during the follow-up, which was 3 weeks for the primary clinical outcome, 12 weeks in total. But she says that if she could do it again, she would do it again all the same. She explains that in her mind, in the psilocybin experience, psilocybin came to her and told her, "How dare you come to me? You ask for help, you don't even know who you are." And she was left with one possibility: continue living in despair or killing herself. That was very tough. She came out of the experience feeling like she had disappointed everyone, and she really needed a lot of support. And that's an important point. She had support from her mom, from a friend she credits, also from the research team initially, but that stops at some point. But she says that for her, this was really the turning point to go deeper and to start a healing process that was not just symptom management. And I recommend you to go and listen to that. And again, with a point of caution, like she was able to make something out of it. it might not be the case for everyone who has a very challenging experience. More generally, we witness now a general desire to better characterize and understand challenging psychedelic experiences. There is a lot of science about that right now. Actually, yesterday an article was published, but I had already sent the presentation that says, understanding adverse effects of psychedelics, or I don't remember the name, but something like that. So these are more the risks. Now I want to go towards the benefits, but Olivier, what time is it?
10 minutes left.
10 minutes left, okay, cool. Q&A included. So I wish I had 1 hour to walk you through the clinical data from the contemporary research, but I don't have time, although I think you will cover some, probably, Marc? No? Maybe not? Okay, well, let's just go for it. So one of the first research of the contemporary, of the Renaissance, let's say, was into treating anxiety and depression associated with life-threatening diseases, including cancer, which you could also refer to as existential distress. And there were actually quite a few studies. Here I'm just going to show the results of one study, which included 29 participants. Half received a high dose of psilocybin, half received niacin, which is it's a placebo. Basically, it will itch a little bit, but it really is a placebo. And in the framework that I've shown you before, preparation, dosing, integration. And what we can see, and then there was a crossover. So the people who got the placebo got the active dose. And here you see that in blue, you see the people who received the substance, the psilocybin, and in pink, you see the people who didn't receive it. And then, no, I think it's actually the opposite because it's response rate. So anyways, you see that one group is doing significantly better than the other, and it's the pink group, and they have received the substance. And then after the crossover, so when everyone received the substance, you still see a visual difference, but it's not statistic. So meaning that both groups, do the same amount of better, and this is response rate. So it's the people who actually responded to the treatment. That's defined differently across study, but you need to have a certain change in your score on a depression scale. And this is actually an anxiety scale, and this is the depression scale where we see a similar pattern. And what was quite interesting in this study is that you see that at 6.5-month follow-up, after one single dose, this significant improvement is sustained with decreases in depression, anxiety, existential distress, and increases in quality of life and attitude towards death. And in fact, one of these studies of existential distress associated with life-threatening cancer did a follow-up 4.5 to 5 years after the dosing and found that in the people that were still alive, there was a sustained improvement. But at this stage, there could be so many confounds, but it's interesting to note. And here you just see there have been a bunch of studies for this indication with psilocybin and with LSD. And here, that's a meta-analysis which pulls together evidence from depression studies. So depression as a secondary, diagnosis. These are the studies in people with life-threatening diseases, and as primary diagnosis. These are the people with major depressive disorder or treatment-resistant depression. And you can see that, so basically, this is the line. This is in favor of psilocybin, and this would be in favor of the placebo. And you see that across all studies, the results are in favor of the people of receiving the psilocybin. People get better with the psilocybin than with a placebo, with an effect size of 0.9, which is a large effect size. Here again, for instance, this study, it's very small, but this study, Von Roth, their primary clinical outcome was 7 days after receiving the psilocybin, and the study was over 2 weeks after receiving the psilocybin. So that's the length of the improvement. When we then read in the media, psilocybin cures depression, we need to take it with a little bit of caution. So there have been promising preliminary results for other conditions. MDMA for post-traumatic stress disorder, there we have quite strong data, and then more preliminary data for obsessive-compulsive disorder, generalized anxiety disorder, substance use disorder, and anorexia nervosa, and actually a bunch more. Interesting to note is that MDMA-assisted therapy for PTSD, post-traumatic stress disorder, as well as psilocybin-assisted therapy for major depressive disorder and treatment-resistant depression, received the so-called breakthrough therapy status from the FDA. So we always call about breakthrough. What does that mean? It actually means that the process of researching is made easier so that it can go faster, and the status is granted to treatments that show, tremendous potential in difficult to treat conditions. And we have a bunch of ongoing clinical trials in other disorders. There is a big one, European one, that's going to start in palliative care. Very excited about that. The limits. I mean, can everyone read this? So here again, I wish I had 1 hour to construct and then deconstruct or partially deconstruct this limit. But yeah, when someone gets a psychedelic, they will know, the therapist will know, and the standard today is to conduct double-blind randomized control trial where basically you don't know what you get so as not to induce a placebo and a nocebo effect, especially when you have high expectancy effects, like with psychedelics, which have been, talked about a lot in the media. I don't think you keep blinding with antipsychotics. I don't think you keep blinding with, sleeping pills and so on. But these were all marketed before this high standard of rigorous research became effective. Another problem is sample representativeness. One part I showed you, there are many people that we cannot include in these studies. Also, there is less access, Well, the access to clinical trials is just not equal among everyone. People from other cultural or socio-economic background might not have so much access, and this asks a question of accessibility once there is a marketing of this treatment, if there is one. I do want to show an effort, for instance, of MAPS in their MDMA for PTSD study. In a historic first, to our knowledge, for psychedelic treatment studies, participants were identified as ethnically or racially diverse encompassed approximately half of the study sample. So I have to conclude, and I want to give you some thoughts to carry forward in the day. First, we see that it seems to be effective or provide some relief, or some healing across a bunch of psychiatric disorders or mental health problems. And so that raises the question of transdiagnostic efficacy. You have different disorders that are expressed with all kinds of different symptoms, but do we have to treat the symptoms or perhaps a common underlying factor? And here is a lovely quote that illustrates this from a participant in a trial of psilocybin-assisted therapy for life-threatening cancer. I feel like a whole bunch of crap has been dumped off the surface. This stuff that made my world shut down so much and made me look at the ground and watch the clock numbers clicking by. There is life and so many things going on. Just watching that tree over there blowing in the breeze, seeing people in the street, and all the different people in vehicles rushing by. I just feel good about being alive. It's always there. We just don't notice. And I'm trying to notice and not forget that I can see it at any time. I can hear it at any time. It's like waking up in the most profound way. That this is really what life is. It's really like this. We are just not noticing. And I want to leave you with a last quote from an article that was published recently, Beyond the Numbers, Reimagining Healing with Psychedelics for Eating Disorders. And I think this can be extrapolated with, healing from human suffering or healing from many different psychiatric conditions. The author suggests, while further research is needed to fully elucidate its efficacy and safety, psychedelic medicine may offer a promising avenue for empowering individuals in their recovery journey by fostering the sense of hope, autonomy, and agency that are crucial for long-term freedom from the cognitive, emotional, and behavioral symptoms of eating disorders. The collection of our work also highlights the importance of the lived experience voice, meaning people who live with the disorder that's, being tested on to treat, beyond the confines of formal study, and a unique potential for psychedelic medicine beyond what can be captured by research measures alone. The research and practice of psychedelic medicine can also serve to inform the evolution of conventional medical and psychotherapeutic approaches more generally, including the potential importance of love and spirituality as legitimate healing technologies, and the integration of intergenerational and socio-cultural influences in the understanding of eating disorders, and others, I suggest. In fact, the field could benefit from broadening the conceptualizing of the etiologies, causes of eating disorders, thereby enhancing psychological safety for those we serve. And I'm just going to leave you with these words. Thanks.
We have time for one question. Normally, most people have microphones. You just push the button, or there are also mobile microphones going around.
What? Ah. Il n'y a pas de question. There is no question. Yes?
I don't know pretty much anything about psychedelics beyond stereotypes and cliches, so I would like to know, what do you think is the biggest misconception about psychedelics? The most widespread, the most common misconception?
That they are bad.
Thank you, Laetitia. Warm applause.